Antibiotic overuse in the outpatient setting threatens patient safety and public health by contributing to rising rates of antibiotic resistance. Outpatient antibiotic stewardship programs can address antibiotic overuse by considering the behavioral motivations for clinician prescribing. My name is Amir Moharib. I'm an infectious disease physician at Massachusetts General Hospital and an instructor at Harvard Medical School. I co-authored with my colleagues a commentary about how behavioral economics can provide lessons to apply to outpatient medical practices to address antibiotic overuse. This article will appear in a forthcoming issue of the Mayo Clinic Proceedings. Antibiotic overuse is the prescription of antibiotics when they are not medically necessary, or for durations longer than necessary, or the use of broad-spectrum antibiotics when narrower spectrum agents would be equally and often more effective. This is a major problem in the US and around the world. In the US, more than 1 in 10 ambulatory visits result in an antibiotic prescription, and an estimated 30% of these are considered inappropriate based on either patient presentation or the final diagnosis. There are many complex motivations for clinicians to prescribe antibiotics. We highlight 3 motivations in our article. First, clinicians may overestimate the risk of bacterial infection, even when the probability of true bacterial infection is rather low. This might be because the consequences of bacterial infection are immediate and directly borne by the treating clinician and patient, whereas the risks and the hazards of antibiotic resistance are more long-term. They're less visible to the treating clinician, and they are distributed across the medical system. This is similar to the so-called tragedy of the commons, a concept in economics which shows that individuals can act in a certain way to displace hazards away from the individual and onto the collective system. A second motivation is action bias, where individuals tend to perceive an action as more beneficial than a decision for inaction, even if that action is inappropriate to the specific circumstance. This happens frequently in times of diagnostic uncertainty. Clinicians may be inclined to assign a misdiagnosis, but with a proven treatment plan, rather than settle in a state of diagnostic uncertainty, or with a diagnosis that just involves continued monitoring and no recommended action. We also discuss the role of patient satisfaction as a motivator for antibiotic use. For example, a recent study of telemedicine encounters for upper respiratory tract infections found that antibiotic prescriptions were associated with higher patient satisfaction scores. This finding is particularly concerning in light of the substantial shift from in-person to virtual outpatient encounters over the past year due to the COVID-19 pandemic. How can we use this information to address antibiotic overuse? Evidence-based strategies in antibiotic stewardship can be harnessed to reduce antibiotic overuse in the outpatient setting. We argue that strategies that focus on prescriber behavior should be an integral component of these programs. One successful method of changing clinician behavior may be in choice architecture, or the deliberate presentation of choices within the decision-making environment. We describe in our article several examples of choice architecture being tested or observed in outpatient clinical practices. One example is a concept called relative social ranking, which is the tendency for decision makers to choose options that they know that their peers have also chosen. This is seen when outpatient practices feed back to clinicians their antibiotic prescribing behaviors in comparison to their best performing peers. Another concept from behavioral economics that can be employed in the outpatient setting is called pre-commitment, which is when a decision maker makes a public commitment to certain principles before she or he enters the decision-making environment. One study showed that hanging a poster in an outpatient practice wall in which clinicians of that practice express a commitment to reduce antibiotic overuse resulted in 20% lower antibiotic use than in control practices. To conclude, the clinical and economic burden of antibiotic resistance in the United States is reaching a crisis point. Clinicians contribute to antibiotic resistance through antibiotic overuse, but the motivations to do this are quite complex. As we improve our understanding of the behavioral contributions to these practices, we may derive novel strategies of behavioral change that do not reduce clinician autonomy and do not compromise on patient safety. Thank you.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.